دلوقتي في البرزنتيشن ده هنبدأ مع بعض ان شاء الله الفراكشر اوف ذا تيبيا او الفراكشرز بالاحرى اوف ذا تيبيا، لان بيجي فيه انواع مختلفة من الفراكشرز. Fractures of the tibia, it is very common in dogs and less common in horses and cattle. دايما بنلاحظه في البيت animals سواء في الدوج او في الكات، لكن في اللارج animal في الهورسز والكاتل بيكون نسبة حدوثه قليلة جدا. الميد شافت oblique or spiral fractures are the most common varieties، يعني ده اكتر حاجة بتحصل في الميد شافت، اما oblique او spiral fractures. البروكسيمال and distal epiphyseal fractures can also occur but less than the above type، يعني اقل شوية من الميد شافت fractures. الاتيولوجي او الاسباب اللي بتؤدي الى حدوث الفراكشرز of the tibia: direct trauma such as kicking, falling or slipping of the animal، يا اما اترفس او حصل فيه دايركت تروما باكسيدنت او ما الى ذلك، او وقع بطريقة خاطئة او اتزحلق على الارض، ايا كان السبب فهو تروماتيك كوز. يعني اكسيدنتال ديورنج ريس، ممكن اثناء السباق في اللارج انيمال اللي هو في الاكواين مثلا، وفي حالات الدوجز برضو في حالات الاكسيدنت بتاع الموتور كار اكسيدنت. constitutional weakness in the bone structures، ده predisposing factor لحدوث الفراكشرز او الكسر، نتيجة ان هي فيها اصلا weakness او constitutional weakness، ضعف في التركيب بتاعها من الاساس. الساينس او الاعراض اللي بلاقيها عند الحيوان اللي عنده tibial fracture: in case of complete fracture, inability to bear weight on the affected limb and marked soft tissue swelling and crepitation. دي الايديال ساينس بتاعت الفراكشرز. وزي ما قلت لكم قاعدة ان في لو حصل كسر في اي عظمة من عظام القائمة الخلفية او حتى الامامية، يبقى الحيوان ما بيحملش على رجليه خالص، بيشيلها من على الارض، وبتلاقي مكان الكسر في ماركت سويلنج، وبالمانيبيوليشن بتلاحظ او بتسمع الكريبيتيشن ساوند اللي هو صوت الخرفشة بتاع الفراكشر دي اندز مع بعضها. والكريبيتيشن may be heard may be felt، يعني حتى ممكن ما تسمعوش بالودن او ما بيبقاش واضح في السمع، لكن من خلال الحركة بتاعت ايديك ممكن تحس بيه وانت بتحرك التو فراكشرد اند مع بعضهم. Craniomedial overriding of the proximal fragment in relation to the distal fragment frequently results in an open fracture، يعني الجزء المكسور اللي فوق من بيطلع لقدام ويركب على الجزء اللي هو تحت المكسور برضو، وممكن نتيجة الاوفر رايدنج بتاع التو فراجمنتس على بعضهم دول ممكن يعمل لك اوبن فراكشر، يعني بيفتح الجلد والسبكوتينس تيشو والسوفت تيشو في المكان ده، فممكن تلاحظ خروج العظم حتى من جرح في هذا المكان. Fractures of the proximal and distal growth plates produce a lateral deviation of the limb distal to the fracture، اللي هي بيسموها angulations، يعني عاملة زاوية في المكان ده. يعني لو اتكسرت البروكسيمال او الديستال اند في المكان ده بتبص تلاقيها عملت زاوية angulation في المكان بالتحديد، وبيبقى شكله واضح جدا على الحيوان. incomplete fractures الحقيقة ده بيبقى صعب جدا تشخيصه الى حد كبير، can be difficult to diagnose، لكن الهيستوري of marked lameness with acute onset and pain on palpation. ده بيساعد شوية إلى إنه ممكن يوجه تفكير إلى إن يكون في حصل incomplete fracture. اللي بيأكد لي طبعا حاجة زي كده هي الاكس راي علشان يبين العظمة إذا كانت مكسورة أو لأ. ال diagnosis depends mainly on clinical symptoms and X-ray. ال clinical symptoms في حد ذاتها diagnostic، انت ممكن تشخص من خلالها، لكن لازم اعمل confirmation لل clinical symptoms دي او اعمل confirmation لل diagnosis بتاعي بان انا اعمل X-ray examination. ال prognosis unfavorable prognosis in large animal while favorable in small animal. يعني ممكن سهل جدا ان احنا نعالجه في السمول انيمالز، لكن بيبقى من الصعوبة ان احنا نحاول نعالج فيه في اللارج انيمال. التريتمنت اوف tibial fractures. بداية لو الكسر عندي في ال upper 2/3 of the tibia it is very difficult to immobilize. بيبقى صعب جدا ان احنا نثبته، لكن الكسر في الديستال ثيرد بيبقى سهل جدا في العلاج بتاعه and can be stabilized somewhat through application of full limb cast placed as high as possible to incorporate the stifle. بيشمل معايا الستايفل، يعني من تحت لحد ما اعدي الستايفل. ده full limb cast. ده مع استخدام التوماس سبلنت. This is more effective for young falls than it is for adults. يعني ينفع ان انا اعمله في اليانج فولز للمهار الصغيرين او الامهار الصغيرين، لكن في الادلت ده ما ينفعش نهائي. Transverse fracture of the shaft is treated by intramedullary bone pinning أو intramedullary fixation. The site of pin entry is just medial from the insertion of the medial patellar ligament. وطبعا حضرتك هتبقى عارف بعد كده ازاي تحدد الميديال باتيلر ليجامنت. just medial للانسيرشن بتاعه هو ده السايت اوف entry of the intramedullary pin. Oblique or spiral fracture is immobilized with intramedullary pin and supported by circulage wire. circulage wire band. السيركلاج ده عبارة عن ستانلس ستيل واير بنلفه حوالين السبايرال او الاوبليك فراكشر. ده مع الانتراميدالري بن، يعني الاتنين مع بعض، التو مينز مع بعض او الطريقتين مع بعض، انتراميدالري بون بيننج زائد سيركلاج واير حوالين العظمة اللي مكسورة اوبليك او سبايرال. In case of compound fracture, all fragments and contaminated tissue should be removed and the wound treated with cod liver oil and antibiotics. cod liver oil عشان يشيل النكروتيك تيشوز، والانتيبيوتكس عشان لو في اي مايكرو اورجانيزم موجود في المكان او infection. Euthanasia is advised for adult horses that have sustained severely comminuted fractures. ما لوش حل غير ان احنا نعدمه، او بيسموه بقى الاعدام الرحيم او الموت الرحيم. euthanasia of the adult horse affected with tibial fracture. زي ما احنا شايفين دلوقتي قدامنا دي السيركلاج وايرنج. السيركلاج يعني بتلف حوالين العظمة كلها في الدياجرام اللي فوق ده، ودي طريقة بتاع الابليكيشن بتاع السيركلاج اللي هي تحت. وصورتين الاشعة اللي انت شايفهم دول ده صورتين اشعة لحيوان او لدوج كان عنده تيبيال فراكشر وخف. يعني الصورة دي بعد ما حصل هيلينج للعظمة، زي ما انت شايف الكالس موجودة او الكالس فورميشن موجودة، وفي جزء منها معمول له سيركلاج، وفي اللي تحت ده معمول هيم سيركلاج. هيم سيركلاج اللي هي نص العظمة بتخيط السلك جوه، ده بتدخله داخل العظمة من الناحية دي وتخرجه من الناحية التانية في السبايرال او الاوبليك فراكشر. لو احنا بصينا على الدياجرام اللي فوق ده، ده فول سيركلاج، يعني بتلف حوالين العظمة كله، ده لفة كاملة وبتلوي السلك لحد ما بيبقى completely stabilized، بيبقى في مكانه complete encircle to the bone. الهيم سيركلاج بقى اللي هي بتاخد نص العظمة، يعني ب- بتعمل خرم في الفراكشر اند من الناحية دي، وخرم في الفراكشر اند من الناحية التانية، وتاخد غرزة كأنك بتلف حوالين نص العظمة بس. يبقى عندي سيركلاج او الفول سيركلاج والهيمي سيركلاج. الصورة دي اعتقد ان عمرها حوالي من 12 او 13 سنة، حاجة زي كده. دي في ميشيغان ستيت يونيفرسيتي في امريكا، واللي جنبي دون البروفيسور تشارلز دي كامب. تشارلز دي كامب ده متخصص في السيرجري اوف سمول انيمال. تخصصه الدقيق في العظم بس، بيشتغل في العظم بس. الصورة دي انا مش جايبها علشان افرجها لكم. هو الحقيقة كان متخصص تقريبا في التibia، وفي العظم بتاع الهايند لمب بالتحديد، ما بيشتغلش غيره طول عمره وطول حياته في ابحاثه كلها. فهو الحقيقة كان عامل فيديو آه، عامل فيه اندكشن لتيبيال فراكشر في دوج، وعمل له تثبيت بانتراميدالري بون بيننج واكسترنال فيكسيشن. فاداني الفيديو ده كاهداء يعني منه، وكان عامل الفيديو ده قبل الصورة دي مثلا بسنين طويلة برضو، يعني كان لسه شاب شوية عن كده، كان يمكن دماغه كان لسه فيها شعر شوية. على اي حال هسيب حضراتكم مع الفيديو، هتستمتعوا بيه ان شاء الله.
Hello, my name is Dr. Charles DeCamp. Today we're going to be repairing a short oblique midshaft tibia fracture. First, you're going to complete a limited medial surgical approach to the tibia. We will then create the short oblique tibia fracture for you, and then you'll get a chance to repair the fracture with an intramedullary pin and a 2-pin external fixator. Let's begin by looking at the first diagram. This is a cranial caudal view of the fractured tibia with the completed fracture fixation. After we fracture the bone for you, you'll provide axial stability by inserting an intramedullary pin from proximal to distal. Additional rotational stability will be provided by a 2-pin, 1-bar external fixator. Let's go to the anesthetized dog and review your surgical landmarks. We are going to repair a short oblique midshaft tibia fracture using an intramedullary pin and a 2-pin external fixator. There are 4 landmarks we need to consider during this procedure. The first is the medial collateral ligament of the stifle, located here, the tibial tubercle, medial malleolus, and the last landmark isn't marked, but you can see a gentle shadow of the medial saphenous vein coursing over the midshaft tibia. and we'll be seeing that structure during this procedure. Let's go to a diagram to illustrate the involved anatomy. This is a medial view of the dog's leg with all of the skin removed. Note that the tibia lies just underneath the skin for the entire length of the surgical incision. You may see some of the flexor muscles, just caudal, to your surgical incision. The cranial tibial muscle will be seen cranial to the tibia. This is a second diagram as seen through the surgical incision itself. Please note the additional structure. The cranial branch of the medial saphenous vein will likely cross your surgical incision in the midshaft area. You may or may not see this structure depending on where you've incised the skin. Procedure. We'll make approximately a 4 centimeter incision in the midshaft tibia region to include the middle portion of the bone. I need to get a little deeper here. If you are not careful, you can pick up the saphenous vein and significant hemorrhage can occur. We need to control the small cutaneous bleeders. We have hemostats in place. We need to extend our incision through subcutaneous tissues. You can see the medial saphenous vein at this point. Depending on the exact location of your incision and individual variation, you may need to dissect along the medial saphenous vein with Metzenbaum scissors. This is done by grasping the loose fascia along the side of the vein and mobilizing the vein by cutting through that fascia. You can then retract the vein one way or the other depending on what you're doing at the time. Sponge, please. We can then take our scalpel blade and excise through the subcutaneous tissue all the way down to the bone itself. You can then use a subperiosteal elevator or a sharp pair of scissors to elevate the periosteum from the bone. We're going to need a pair of retractors, small retractors here. Because we are going to produce this fracture, we need to dissect a little bit more of the tissue than you might wish to do in a fracture repair. You must get all the way cranial and caudal to the bone. 15 blade, please, and sponge. Caudal to the fracture, one must incise the periosteum, as it seems to have quite a firm attachment once you've incised that periosteum, you can retract the muscle caudally. This exposure should be adequate for the remainder of our procedure. We're now going to create a fracture. This is done again by passing a wire saw, a giggly wire saw. I'm going to need your help here, Curtis. I need retraction. And we'll do a small hemostat. Okay, if you can retract, please, and hold the limb down. Retractors are used to protect the muscle from the saw cut. They cut through the fibula. And part of the way through the tibia, we'll then use an osteotome to create the short oblique fracture. There often is some hemorrhage at this point from the medullary canal. In this dog, it doesn't seem to be too bad. This hemorrhage is controlled usually in 5 minutes. There's no way that you can clamp the medullary bleeders. Our next step is to place an IM pin in the proximal femur. In order to do that, it is easiest to first apply a Kern bone clamp to the proximal tibia so that you can control it during pin placement. Suction, please. Pin selection is based on the size of the medullary canal, and because we're going to repair a tibia, the IM pin chosen will be a little smaller than the usual rule of thumb. We're going to choose a pin about 1/3 of the width of the medullary canal. This smaller pin size is chosen, this is about right. This smaller pin size is chosen so that when we drive the pin from proximal to distal, the pin must take a slight bend at the caudal cortex of the tibia. This smaller pin will then bend slightly and allow the pin to extend to the fracture site without exiting the cortex. Let's go to a diagram to illustrate proper intramedullary pin placement. This is a lateral view of the fractured tibia. This is a view of the tibia from the top in this region. This is the medial aspect of the tibia and the lateral aspect of the tibia. This would be the tibial tubercle. Pin placement should occur about halfway between the medial collateral ligament and the tibial tubercle, along the medial surface of the tibial plateau. Once the pin has entered the bone, it will bounce off the caudal cortex, extend past the fracture site, and all the way down to the level of the malleolus. You don't want to extend the pin past the top portion of the malleolus, because if you do, you'll enter the tibiotarsal joint. Also have prepared a second measuring pin so that we can use this second pin to judge the distance that we place the pin in the distal tibia fragment. Key, please. Our pin placement will be a little bit further cranial than half the distance between the medial collateral ligament and the tibial tubercle. At this point, you can palpate a plateau on the top of the tibial tubercle where pin placement is easiest. We're going to make a small little skin nick that will help us get the pin through the skin without causing too much trauma. The pin is then placed through the skin and subcutaneous tissue, and then while directing the pin towards the distal fracture piece, use 1/4 inch turns to drive the pin in place. As we run out of pin, we have to use our chuck key to extend our pin. We're going to continue to drive the pin until it exits the fracture site. Just like that. We'd like the pin to stick out past the fracture site no more than 1/8 of an inch so that it doesn't interfere with our surgical reduction. We can take the Jacob's chuck off the IM pin at this point to improve our manipulation. The second Kern bone clamp is applied on the distal fracture segment. Suction, please. We will now reduce the fracture using our 2 Kern bone clamps. You can run this thing for me, Curtis, please. Just pull it up so I can. Okay. We're going to reduce our fracture using 2 Kern bone clamps, achieving as perfect reduction as is possible. That looks pretty good. Can I have a sponge, please? Curved hemostat. You must be careful and examine all the fracture surface, because even though it may look well reduced at one site, be sure and check the sides. You may have a significant gap opening on the opposite cortex. Could I have the speed lock forcet, please? Oops. Once you have the fracture reduced, you can use either another Kern bone forceps or a small speed lock, as we're attempting to do, in order to maintain the reduction while you're completing the remainder of your fixation. You need to have you hold it cranially just a little bit. rotating it a little bit. I got it too. Yeah. Once the speed lock is applied, the fracture is reasonably secure. However, any extra movements can dislodge the fracture, so be careful in manipulating the fracture site. We're going to drive the pin proximally from the tibial tubercle distally to the medial malleolus. We would like to drive the pin to the top of the medial malleolus so that we avoid the tibia tarsal joint. We'll remove our Jacob's chuck so that we can take our measuring pin again and check the distance to the medial malleolus. I can see that we have to drive the pin a little less than a centimeter, then we can stop. We'll check our distance one more time with the intramedullary pin. We can see that we've driven our pin just to the top of the medial malleolus, right where the landmark has been marked. Our pin purchase in the distal fracture segment should be more than sufficient. Next, we're going to apply the external fixator. This will be a 2-pin external fixator. This diagram will illustrate proper external fixator pin placement. Each pin is placed approximately half the distance between the fracture site and the ends of the bone. Start the fixator pins perpendicular to the bone, and as soon as you feel the pin biting the bone, angle the pin and drive it through both cortices. The full trocar point of the pin should extend through the second cortice. Once both fixator pins have been placed, 2 clamps and a connecting bar can be placed on the outside of the skin, completing the external fixator. Let's go back to the dog and place the proximal pin first. The site chosen should be about half the distance between the fracture site and the top of the bone and just caudal to the incision. We're going to make a small skin nick, ease our pin through the skin. Pin is placed through the skin and almost immediately underneath the skin is the bone. This pin, as it hits the bone, should be started at approximately 90 degrees. Once the pin begins to bite the bone, back it off to about 70 degrees with respect to the bone. As the pin goes through the first cortex, you'll find a relief of pressure you'll hit the second cortex and resistance will be met again. This can be quite strenuous if the dog has hard bone. As the pin goes through the second cortex, you feel less resistance and you know that the pin is in the proper place. Our second pin will be placed in the distal segment. We're going to choose a site about halfway between the end of the bone and the fracture site, and just caudal to the incision. Make a small little skin nick. Now I'm going to have to move to the other side of the table. That's not bad. We place the pin thumb forceps, please. We place the pin through the skin, directly underneath is the bone, using the Kern bone forceps to stabilize the bone. Start the pin in at about a 90-degree angle. And then as it bites the bone, back it off to approximately 70 degrees. Be as precise as possible with the external fixture pin to prevent premature loosening of the pin at a later date. I've gone through one cortex. And now have completed placing the pin through the second cortice. I can move back to the original side of the table. You should always inspect your fracture site to make sure that reduction has been achieved. Our reduction is still good, so we can remove our Kern bone forceps at this point. This may allow us to see the fracture site a little bit better at this point. We have very good reduction right across this area. The speed lock is still holding the fracture site together, so we're going to leave that in place. The next step is to apply an external fixator two fixator clamps are slipped onto the external fixator pins. The connecting bar is advanced. This is a perfect fit. The individual clamps should be about 1/4 of an inch or so above the skin without any portion of the clamp actually touching the skin. Make the clamps finger tight and then use a small wrench to tighten the clamps the rest of the way. Always secure these clamps as tight as possible. We should be able to remove the speed lock forceps from the fracture site at this point. Let's put our retraction in one last time to examine our surgical reduction of the fracture. We can see our reduction is quite good at this point. Our fixation is completed. Let's retract one more time and flush the wound before closure. Note that when we rotate the lower leg, the fracture site is quite secure. No visible movement is seen. This should be quite secure fixation for the healing of this injury. Closure consists of 2 layers. The first layer is an interrupted subcuticular layer. There may be some tissue that you can close deeper, and it looks like that's going to be the case. So that in this dog we'll do a 3-layer closure. Closure is always more difficult because of the presence of the external fixator. Always avoid the medial saphenous vein. With your sutures. The second layer of closure will be an interrupted subcuticular. Final layer of closure is a simple interrupted pattern in the skin. At this point, we would take an x-ray to check our pin placement. Before x-rays are taken, we would cut off the external fixture pins. In order to cut off the IM pin at the closest possible, an assistant can push down around the skin while you place the cutter. Why don't you remove that now? And then cut off the pin with a quick, sharp action to prevent trauma to the skin. The skin can then be pulled up gently over the top of the pin, and we have a completed procedure.